So hi, everyone. My name is Charisse Iglesias. I'm the Training and Resource Director at Community Campus Partnerships for Health. And I want to welcome you all to our session on engaging community health workers to achieve health equity in North Carolina. But before we get started, I want to pass it over to our Spanish interpreters who will give y'all some instructions.
Thank you, Charisse, and welcome everyone. My name is Sandra. I am, along with my co-interpreter Annabelle, I am your Spanish. We are your Spanish interpreters for the day, and we will give you a couple of instructions to access the interpretation feature. So we'll do this both in English and Spanish, and we appreciate that you're patient with us. Buenos días a todos, les damos la bienvenida. Mi nombre es Sandra. Estoy con mi co-intérprete Annabelle. Y juntas vamos a ser los intérpretes del día de hoy del español. Vamos a darles algunas instrucciones para acceder a la función de interpretación en Zoom, así que les agradecemos que su paciencia, porque lo vamos a hacer en inglés y en español. So if you're joining from a computer, you will find the globe icon at the bottom of your screen. Please click that globe icon and choose language interpretation and then the option English. This is important so that if anyone participates in Spanish, you're able to listen to their participation in the language of your preference. If you're joining from a Chromebook computer or a phone call, you won't have access to these features. Entonces, si están uniéndose desde una computadora personal, pueden hacer clic en el menú de su pantalla, encontrarán un icono de globo terráqueo, hagan clic en este icono, elijan la opción español y pueden elegir la opción silenciar audio original, ya que esto evitará que tengan el sonido de la sala. Si están en una computadora Chromebook o en una llamada telefónica, no van a poder utilizar esta característica. If you're joining us from a mobile device, tap lightly on your screen and on the three-dotted menu that says more, you might have to slide your screen right. You will find the option language interpretation, then choose English and press done. In both options, remember not to mute original audio or you won't be able to hear the main room. Si están en un dispositivo móvil, hagan clic ligeramente en su pantalla y encontrarán un menú de 3 puntos. Tal vez tengan que deslizar la pantalla hacia la derecha y en ese menú de 3 puntos encontrarán la opción de interpretación de idiomas. Elijan español y presionen listo o done para activar la función de interpretación. We hope you have access to this feature with no issues, but if you have any trouble accessing it, please leave us a message in the chat and we will be happy to help. Si tienen algún problema accediendo a esta característica, pueden dejarnos un mensaje en el chat y nos dará mucho gusto apoyarles. So I'm going to hand the microphone back to Charisse. Thank you very much.
All right, thank you very much. Let's move on to the next slide. So just to better get to know who's here, we're going to put a poll question up. Just spend the next 30 seconds to a minute answering. How familiar are you with the work of community health workers in your community? Again, this is just to get a gauge of who's in the room with us. So I think I put the poll question up. How familiar are you with the work of community health workers in your community? Very familiar, somewhat familiar, not at all familiar. Okay, nice. Thank you. Keep going. 65% participated. Take the next 10 seconds to answer the question. Very familiar. Okay, we got some experts in the room. So feel free, to contribute to the conversation, use the chat, as Alan said. Feel free to raise your hand if you want to contribute something. We want to make this into more of a peer learning space. Yeah, okay, I'll end the poll there. Okay, so mostly very familiar, somewhat familiar. Okay, good to go. Okay, we're very excited. We have 3 really excellent panelists who will share their experiences, either working as community health workers or working with And we have some cool stuff for you. So thanks for participating in that. So a little bit about our hosts. I'll pass it off to Alexis Hill, who is the CCPH engagement strategist, who will introduce NC CEAL.
Hello, can you guys hear me okay?
Yes.
Okay. So NC CEAL, the North Carolina, NC CEAL, it stands for the North Carolina Community Engagement Alliance Research Team. It is brought together by Community Campus Partnerships for Health and the University of North Carolina Center for Health Equity Research. NC CEAL is one of 21 teams engaged in the NIH Community Engagement Research Alliance against COVID-19 in the disproportionately affected communities. CEAL, they call it the CEAL Network. And just some new news that we got from recent news that we got, NC CEAL has now been approved for their year 4 proposal. So for the next 4 years, we'll be focusing on food insecurity and just food. So we're really excited for that opportunity. So yeah, thank you.
Thank you, Alexis. And Community Campus Partnerships for Health is a nonprofit that promotes health equity and social justice through partnerships between communities and academic institutions. And we're all very happy that you're all here. So an icebreaker, we'd love to know in the chat, please share your name and your pronouns. And what's your favorite spring flower? Feel free to use the emojis in the chat if there's an emoji that represents your spring flower, or you can type it out. My favorite spring flower is yellow daisies. Yellow is my dad's favorite flower. He loves yellow. And also daisies just seem so happy. Alexis, do you have a favorite spring flower?
I don't know if it's really a spring flower, but my favorite flower would have to be a lotus flower, just because of the meaning behind it. It's always it grows in the most like muddiest, the muddiest kind of like not the prettiest locations, but it ends up growing to be the most beautiful flower. So I think that kind of explains my mood today and how we start somewhere, but it just can grow to be this beautiful thing. So I'm super excited. So I'll pass it back to
Yeah, thank you. Okay, bleeding hearts, tulips, roses, tulips, yeah, sunflowers, tulips. Awesome. Okay, feel free, keep putting in your favorite flowers, use the emojis, explore that. I'm going to move forward with the slide. So our agenda today is a very brief overview of community health workers. Most of us seem to be experts here, so I'm not going to go into that too much. We're going to have very short presentations from our panelists, a moderated panel discussion, and then we'll close with evaluation and closing. And so what we hope to achieve together in this time is to create new connections with community members and community health workers in North Carolina. We want to describe how community health workers' lived experiences inform their health equity work. And we want to identify best practices on how to engage community health workers in your communities. So a chat storm, I know y'all are still putting in emojis of flowers, but a chat storm, what's one word you would use to describe community health workers? Again, we just want to see how people are describing their lived experiences, based on how familiar you are with community health workers. What's one word you would use to describe community health workers? You can also use more than one word. Knowledgeable, overworked, yes, underfunded, essential for communities' health. I like that, 4 words. Angels, yes, connected, wise, committed, culturally relevant, right? Okay, now, well, we all know what we're doing here. Thank you for participating in that. So just a brief, definition, very simplified. Their community health workers are frontline public health workers who are trusted members and have a particularly good understanding of the community served, right? They serve as a liaison between health and social services and the community to facilitate access, right? So they serve as that unique bridge to improve the quality and cultural competence of service delivery. And obviously there are more than one name, right? Named for community health workers. There's promotores, community health ambassadors, community health representatives, community health navigators, peer health navigators. There's so many different ways to describe the type of work that they do. And just some facts and figures, UNC Greensboro has an 11% projected job growth for community health workers and associated roles between 2018 and 28. And according to the U.S. Bureau of Labor Statistics, they project a 16,000, job expected every year. But to continue the conversation and to on sustainable funding, I'm going to pass it off to my colleague Alexis, who will lead our discussion on sustainable funding.
Yes, thank you, Cherie. And so, as some of you have already mentioned when describing, community health workers, you address the importance of sustainable funding and the importance behind funding for community health workers, because community health workers can engage with marginalized populations. And because, a lot of community health workers are people of color, they come from different, social economic statuses and geography and with the communities that they serve. And so with the community health workers, they're essential. They're very much essential in these communities. And so we need to find a way for community health workers to be embedded into our healthcare community system, because again, they are important. They help kind of drive, and they prove the effectiveness in reducing some of those health equities and the improving outcomes across wide ranges of diseases and conditions. We saw that pre and post pandemic. So yes, and so again, the importance, we heard you, like I said, in the chat, so we understand the importance of definitely funding for community health workers. And so for that, we're going to get ready for our panelists. So we're going to go to the next slide. Oh, we have one chat storm. And so with that, the importance of the funding and sustainable funding, what's one way we can embed community health workers into our healthcare systems? We would love, we would love to be able to hear from you. Kind of want to keep it engaged. So what's one way, or it could be 2 or 3 ways that you think we should be embedding community health workers into our healthcare system?
Can you give us an example?
I want to save the examples for the experts. So I'm going to save the examples for the experts because we're getting ready to go into that conversation. So I'm going to leave that question, or the examples, for the experts. But just looking at the chat, community engaged research, needs sustained funding, Medicaid assistance, create funding. Again, funding has been the common theme that I am seeing. Permanent positions for community health workers, investing in education and training, including them as a team member with clinical teams. Shonda, I see your hand is raised.
Yeah, we kind of talked about this a little bit. How can we get them into the most integral and key places where they are needed? In the ER, in those extended treatment facilities, to serve as that liaison and that point of contact and kind of like that buffer for the family and for the healthcare providers. They are needed, especially now with not the rise of mental health illness, but the exposure and relevance and revealing of how many people are affected by mental health. So definitely in those police departments, definitely on those crisis and response teams, in the areas and in the places to where it's going to make the most impact and bring about that change and bridging that gap and building that trust between healthcare provider and everyday people and community.
Yes. Thank you so much for that wonderful response. Yes, that is 100% correct. And so again, going back into the chat, providing screenings for the hard to reach. Shonda, I think there was a question for you, interested in the ER model and what capacity to community health workers serve. Accessing health services while navigating immigration or other statuses. So these are all wonderful answers. And again, we want to continue. Shonda, yes, I'm gonna pass it back to you.
So, what was the question again? I'm sorry, I heard two things after that.
Now you're fine.
What role would they play in the ER? Was that the question?
They were interested in the ER model. And again, Richard,
So-
if you're able to come off mute, you're able to as well.
So that ER model would look like as soon as a person comes into the ER, the same way a social worker would get involved at a certain point, but the community healthcare worker is there and assigned as soon as the need is diagnosed. Kind of like an assessment or a triage, the way they would triage you for your symptoms. This person is there from day one, from point of contact, letting the family know, hey, listen, this is a service that we provide, that the community and the rendering provider have come up with this to aid and to help you guys with information, with being able to navigate, understanding insurance, community resources, treatment. So they would be there kind of, if you want to think of it like a partner or a buddy, but at that initial point of contact and assessment. Once they come in, boom, there we are. There are the community health workers ready to roll, armed, geared with their resources, with their empathy, their compassion, their knowledge, their skill, and most of all, their presence and willingness to help and serve the families and the providers.
Thank you, Shonda. That was a wonderful response. And again, thank you for that, for answering that question and providing that information. I think that's a great segue into introducing our panelists for today. So we have three wonderful panelists that are going to share their lived experiences around being community health workers. Please feel free to use the chat to share any questions or comments and reflections you have during their presentations. So again, we have Shaquita, who is the founder and CEO of Shackle Free Community Outreach Agency. We have Emily, she's from CCPH, she's an engagement lead. And we have Joyce, she's a public health education specialist from Durham County Department of Health. So we have these three wonderful panelists today that are going to spend the next 5 to 10 minutes each speaking on their lived experiences as being a community health worker and some of the essential things about being a community health worker and some things that we should just be able to take away from this conversation today. So I'm going to first pass it over to our first panelist, Joyce. So yes, I'll pass it to Joyce.
Thank you very much. I appreciate this opportunity to talk to you all and share my experience working with community health workers and working with lay persons who are trained in the community. Back in the early 2000s, I started working with community members to provide training using evidence-based programs. The first program I worked with was Project Direct, and Direct is an acronym which stands for diabetes interventions, reaching and educating the communities together. It was probably educating the community together. It was life-changing for me because it gave me a perspective and an appreciation for what the community can do beyond what I could do as a health professional. And I am trained as a health administrator and a health educator. I was trained also to lead laypersons as using evidence-based programs that were designed by Stanford University called the Chronic Disease Health Management Program. And I was trained through a program designed by Boston University called Matter of Balance on Falls Prevention. And both of these programs cover an array of different topics on managing basic chronic, not basic, but familiar chronic illnesses, those that we deal with constantly: high blood pressure, diabetes, stress, lung disease, heart disease, pain. If I didn't say diabetes, diabetes was one of the most important pieces, and that's why I got involved with it. After going through the training, I was able to train persons from the community to be lay leaders and lead these workshops, which have been researched for over 20 years, now over 30 years, and it's used in numerous countries, and all the states in the U.S., I believe, are using the Chronic Disease Health Management Program. So what was the benefit? We trained persons, lay health workers, and they went out and got the community involved in attending these workshops. The workshops last 6 weeks, once a week for 6 weeks for 2.5 hours. We saw remarkable changes in the communities, and the communities that we mostly worked with we worked with Raleigh, North Carolina, which is really big location. But then we took it to the eastern and western states, western counties in North Carolina that had few people and had few resources, where it was extremely important to get as many persons there. I worked in Hyde County, and Hyde didn't have a full-time physician in the areas where I was working. If you went over to the Ocracoke Island, you may have had a full-time physician, but not in the communities that I worked in. So the persons who were trained there went on to teach people in the churches. The churches were the most important organizations in those communities. And there we started a program called Project Direct Legacy, and we used the lessons we learned from Project Direct, which was a large funded program from the CDC, a research program. And they found that community outreach workers or community involvement was crucial to getting the community to join in and to increase your numbers. In Hyde County, we worked with the toy truckers. What are the toy truckers? The toy truckers were men who had trucks that were their toys. Everybody in Hyde County has a truck, and that was really important to have these wonderful trucks. But they also have the most devastating impact of disease from numerous things like diabetes, and that's what we worked on. We found that when we got lay persons involved, that they made a huge difference in getting people to start walking, eating better, and to get them to the doctor's offices. We got health workers involved, and we partnered with the local health department. And now I've taken the lessons learned from all these experiences to Durham County Health Department, where I continue to teach these programs on managing diseases. And one of the focus is the Men's Health Council. It's a voluntary group that I was able to get a bunch of men together, African-American men predominantly, have come together, and they wanted to be healthier. And I asked them, will you help me design a program that will get community people involved? We have community health workers on staff at the health department, and they got involved with the program. We taught community health workers through these evidence-based programs and community leaders. And then we have several men that regularly meet, and they have become a partnership, a networking group. Why are they so essential? Because they communicate with each other. They value our stakeholders, our community workers, our lay leaders. And before they were community workers, we were just training lay persons, and we call them lay leaders. Actually started with church groups. But they see the community as equal. They see them as essential, and they're not just mere tokens or secondary contributors to health. These community workers, these lay persons were absolutely essential. The community respected them, the community trusted them. One of the challenges that we came across, working with healthcare professionals often can be a challenge because they did not see the community health workers as the best, perhaps, to provide the education in their presence. They thought they should, and fortunately, this is changing, but I had some physicians who felt that they should be the best ones to teach community members about diabetes. And when the community health workers, lay leaders came into the space, I remember being shut down by a physician when I was trying to get one of our participants in the workshop to share her plan. How do you plan to address your health issues? What do you want to do? And that was the topic. How can you change your diabetes outcome? So I asked her, what is your goal? What would you like to do? The physician completely stopped me and said, well, these are the things that you need to do. Horrible. So that's a horrible way to approach it. Fortunately, we don't, I think physicians that worked with us changed because they saw that having role models like yourself were extremely valuable. And I'm going to end by saying that a lot of times we have these little P's and big P's. And one of my community members talked about the little P's and the big P's. The little P's means the persons that you value, but they're not equal. A very quick story. We wanted to do a presentation about how working with the community made a difference. And this was a national conference that was held on the Project Direct. And while we were planning the conference, one of our administrators said, well, when we bring the conference folks together, we want to have speakers from the community to tell what they did, and speakers from our researchers and our clinicians. And she said that for the speakers, I suggest that we give each of them $500 each for their presentation. And for the community members, she suggested that we give each of them a nice token. Our community leader stopped and she says, so I see we're not all equal. So we have little participants, the little P's, and we have the big participants who are more valued. So now we changed the experience, having a community there changed that dynamic so that in the end, everybody received an equal amount of pay. I think they reduced it to $200 each. And this is in the 2000s, so it wasn't bad. But it's absolutely essential that you have people who recognize the value of the community, that the community can trust, and that can advocate for the community. Thank you all. Thanks so much.
Thank you, Joyce. That was amazing. And again, we will have time at the end for questions. So if you guys have anyone in the audience have any questions, comments, or concerns, please put them in the chat and we'll have time at the end to come back and Joyce will be able to answer those questions. And so our second presenter is going to be Ms. Shaquita. So we're going to go to the next slide and pass it to her.
Good afternoon, everyone. I'm honored for the opportunity to present about something that is so near and dear to my heart, and that is CHWs, community health workers, as they said before, ambassadors, whatever you call them. Next slide, please. I am Shaquita Lassay, and I am an IO psychologist, and I'm the founder and CEO, co-founder and CEO of Shackle-Free Community Outreach Agency. Just one slide to just give you a little background about what Shackle-Free actually does. Our mission is to promote holistic well-being. That's mind, body, and soul, equity, and self-reliance. That means helping individuals to operate at their full potential by looking at their whole well-being. To the right, you'll see Maslow's hierarchy of needs. I like to call him the other honest aide because we really rely on him for the structure of our organization. And I'm glad to hear that NC CEAL is invested into food, because we do believe that in order for a person to become their whole self, they can't be hungry. That's one thing that cannot happen. They cannot be hungry and cannot have a place to live. So everything that we do is geared toward this model here of motivation, a model that motivates people to climb from crisis to thriving. Next slide, please. Awesome. So getting to the community health worker, and the things that we should know about community health workers is that it's everyone's responsibility to care for our communities. And what we have found to be a great model to go by is an evidence-based model called the Roma cycle, where we assess the individual needs of the community. We use those assessments to plan events and things like that, or services and programs, implement those, report and look at our progress to see what's working and what's not. And then we evaluate it, compare it with benchmarks. We also look at what's in the community, what informal and formal supports are there, who's working together to build this healthier community. And that's down in the bottom right of the slide. This is actually something that I grabbed from Trillium. So I want to give them kudos for this model, because it really shows you how this issue that we face in our community is all about what's there and what's not there, what gaps are there, what services are there, and actually using that hierarchy on the left here, our guy Abe, to help individuals to fill in those gaps and to, like I said, make sure that the services are there for them to be able to do that. We refer to this initiative as our You Are Well North Carolina initiative. It's our umbrella. It grabs everybody and hopes to help to make them holistically healthy. Next slide, please. If you are a community health worker here, if you're a shackle-free ambassador, throw up a reaction in the chat or either on your screen there. Just let everybody know who you are. If you're a community health worker in your neighborhood and you are defined as the village, you're a village-centered person with lived experiences, you have trust in the community, you can go on streets and go places where no one else can go. You fry good fish when it's time for a community event, and your desire is to make a lasting impact on your community toward holistic well-being, then you are, by definition from CDC, a community health worker and ambassador. Next slide. And I like to say that these individuals turn shackles into armor. That's what they do. This slide here, it shows you a program that we had back in 2011 in which the crime rate dropped from 50 to 1. This is before shackle-free became shackle-free. We had Camp Unity. Our Camp Unity director is on the call today, but this program actually touched everything that was needed. It's our model. It's proven because it did help to drop the juvenile crime rate, but trusted messengers and community health ambassadors ran this camp. They were the grandmas and the grandfathers that sat by the bathroom to make sure nothing, happened, that shouldn't be happening. They were the ones that were in the classrooms. They were the ones that were leading the dance and all the things that were going on. Next slide, please. They're also the ones that know all of these individuals on the top left. And these guys are representatives of our community that have passed on. In Duplin County, where our office is located, we have had more than 30 individuals under 30 to lose their life during the pandemic for various reasons. What Shackle Free does is we bring in community health workers that are able to relate to these systemic inequalities that everyone faces. We use Toys for Tots on the top right. You see our community health workers and our board members gathered together. On the bottom right, you'll see the kids from Camp Unity. The community health workers know all of these people in the community and are able to go up to them and have a conversation. On the bottom left, you're going to see where Shackle Free has jumped in and helped to start in bringing in training, professional training to regular people in our community, our mechanics, our people that work at the corner store, at the grocery store, our barbers and beauticians, people like that have trusted experiences in the community. Next slide, please. What we want to do is change the narrative. We don't want to keep losing our young people. We don't want to keep using our seniors and those with disabilities. So we are proud of the fact that we've trained 101 through Duke. We also have a dynamic Google Classroom that we have just set up, and we've expanded our Mama Khan's Pantry, is what I like to call it, named after my grandmother's spirit of being the oldest of 17 children. And that's making sure nobody's hungry. And then from there, we build on top of that. But out of these 101 certified ambassadors, as you can see, they are trained and continuing to participate in lifelong training. Their digital equity, mental health first aid, civic engagement, voter registration. Look at this snapshot, shows you the outcomes of our community health workers. And I think they deserve a round of applause. They deserve, throw up something in your reactions, because these people are who make things actually happen. How else do you get out 103,000 pounds of food in the community unless you know where to go and you know who to talk to? How else do you provide 644 individuals with support in order to remain employed or to gain better employment? Next slide, please. And this is another slide that shows additional outcomes that our community health ambassadors are able to make happen, tying individuals to services, educating our teens on abstinence. We're talking about a one-stop shop with one-stop people, no wrong door policy, none of that. It's all of these groups like our Good Daddies, our Moms program, working in together and with the community, because none of this happens without partnerships and collaborations. Next slide, please. And I'm going to go ahead and get ready to close out. Some more of our outcomes just to show you here. Next slide, please. This is an initiative we put in the barbershops because we know that people go see their barbers and beauticians more than 20 times a year and may see their physician maybe one time, but everybody's going to the barbershop. We trust them with our appearance. We also trust them with the messages that they send. So we just try to make it make sense. Next slide, please. Register to vote, ask your barber. I'm serious. I think sometimes we get way overboard with who we go to when we're looking to target a population. We go to the wrong people sometimes to get that population engaged. But there's a barbershop in every county, in every state across the whole United States of America. So if we bring it back down, we make it make sense. Next slide, please. Here are a few of our notable projects that we've been working on. Shackle Free was the first to establish in a healthcare facility. So I'm really interested in the ER model. I know it works. Next slide, please. This is another just did you know about community health workers, and also building programs around community health workers. Anybody can initiate a community health worker program because everybody has those. Giving them lifelong learning, empowering the community, giving them opportunity to come out of poverty. It makes no sense that most women that reside in Duplin County only make $10 an hour at textile and meat packing plants. People have much more in them, inside of them than that. The next slide, please. This is the slide that I want to end with. On the right, you'll see our mascot, who is gender neutral. That is free, and he accompanies us to events because, again, we want to be able to have CHWs that are in suits like this that represent just the importance of people being individually, themselves. In 2019, the National Academy of Medicine reported that burnout reached crisis levels, and up to 54, that's more than half, nurses and physicians, and 60% medical students and residents suffer from burnout. Health worker burnout, it doesn't just harm the individual and their family, but it threatens the entire nation. By the end of 2022, the U.S. Bureau of Labor they project the need for 1.1 new registered nurses across the US. And within the next 5 years, there's going to be a shortage of 3 million low-wage health workers, a shortage of 139,000 physicians by 2033, with the gaps occurring in primary care. Health worker burnout affects everything. It affects all of our safety. And I just wanted to end with this one, just because it brings the seriousness of what we're discussing today to the table, of how important it is to use what you already have, is to not downplay the qualities that lived experience and add education and resources bring to a community to help flip the conditions. So that is my presentation. Look forward to interacting with you guys in the upcoming panel. Thank you so much.
Thank you, Shaquita, for that amazing presentation. And again, if you have questions and comments and concerns, again, put them in the chat, because after our last panelist, we'll be having a panel discussion to ask all of these wonderful panelists any follow-up questions, more in-depth questions about anything that they presented today. And so with that, we're going to pass it to our last panelist, Emily. So I'm going to pass it over to you.
Great, thank you, Alexis. Hi, everyone. I'm Emily from CCPH. I'm going to be talking about a program that I worked with prior to joining CCPH. I'm based in Philadelphia, and I worked on a project related to integrating community health workers to promote health access for women affected by female genital cutting or mutilation, which I will call FGMC. So I want to be clear, I am not a community health worker, but I have worked alongside CHWs in the field, and I have learned as much, if not more, from them than I have in academia and in the classroom. So they are the true educators, and I'm just honored to be able to give this presentation on our project. So we can go to the next slide, please. So just a little bit of background on female genital mutilation and cutting and the related barriers to healthcare. We know that over 200 million women and girls worldwide are affected by FGMC on continents across the globe. We don't know how many women and girls in the United States are affected. We don't really have a way to measure that, but we know that they're here because we live in a globalized world, and global health is now local. So there are significant barriers to seeking healthcare for FGMC that are related to both providers and clients themselves. So on the medical provider end, a lot of clinicians are inexperienced in dealing with FGMC. They may not be very educated on what it is. They may have a lot of discomfort working with affected women, lack of formalized training, and lack of cultural competence to really connect with and understand this practice. And then on the client or patient end, there can be significant language barriers, barriers around healthcare system navigation. Many affected women have immigrated from other countries, so there may also be barriers related to insurance status, immigration status, and healthcare related cultural norms and stigmas. And so taken together, all of these barriers result in a lack of preventive care, feelings of alienation from healthcare services, misidentified cases of FGMC, difficult provider reactions like shock and discomfort, and losing patients to care and not having that continuity. So we can go to the next slide. So the Philadelphia International Women's Project was a community-based care system that supported women living with or at risk of FGC in Philadelphia through 4 major approaches. So those were community engagement, peer-to-peer support, clinical services, and provider education. Next slide, please. So this is a project that was funded by the U.S. Office on Women's Health. And there were 3 organizations that partnered to support the program. So one was the Nationality Service Center, which is a resettlement and immigration service provider for immigrants and refugees in Philadelphia. They managed all the federal grant reporting, stakeholder outreach, and relationship management. They have relationships with a lot of other CBOs that support refugees and immigrants around the city, and coordination of program evaluation. I was based at the Drexel Medicine Women's Care Center, which was a university-based OBGYN clinic. We provided specialized care for affected women, as well as medical provider education and coordination of research activities. And the 3rd organization was the African Family Health Organization, which delivers services to African and Caribbean immigrant communities in Philadelphia. They had a wonderful staff of community health workers, or we also called them peer outreach workers, and cultural health navigators. They provided support groups and education, as well as referrals to clinical and social services and accompaniment to clinical services. Next slide, please. So this slide really highlights the benefits and values of having CHWs on our team. So those photos that you see on the slide, those are 2 of our amazing CHWs who are still based at African Family Health Organization. At the top is Salamatu C, who comes from Bamako, Mali. And at the bottom is Dr. Ishraga Dusa, who comes from the Darfur region of Sudan. They were essential to our program because they have cultural and linguistic congruence with the clients that we were reaching. They have direct personal experience with the practice of FGMC, so great understanding of the barriers that inhibit health access and maintenance of care. Having them culturally integrated with the communities that we sought to reach gave us a greater capacity for impact and outreach, greater access to other community leaders and groups that were relevant to the communities. And most importantly, just being able to reach women on the ground where they're most comfortable and facilitate frank, open, and honest discussions. One of the really challenging aspects of working with women affected by FGMC is that there is so much shame and secrecy around the practice. Many women are told to never discuss it. It's very taboo to discuss, and that silence itself creates a lot of barriers to care. And so having these peer support workers and CHWs was so essential to creating a safe space where FGMC could be discussed openly and without judgment. So next slide, please. Yeah, and to expand on that, this is the peer support model that was really kind of built out by our CHWs and our team collaboratively. So you'll see, there are all of these domains in this model, and they're all sort of focused around this central idea of breaking the silence around FGMC, which is so important. So at the top is, you know, having the right staff, having the right people as your CHWs who can really connect on the ground. They provided an understanding of the cultural and religious aspects surrounding the practice of FGMC, the medical and legal implications. You know, many of the women that we saw were also, in addition to just seeking regular clinical services, were also seeking an exam to support an asylum claim. They were, you know, hoping to you know, establish legal asylum based on their FGMC, and so there was a lot of education around that. Healthcare navigation and clinical integration in general. So, you know, many of the women we saw also had health issues not related to their FGMC, but just other health issues that had been unaddressed. We provided support groups and sex therapy groups. I'll get into more detail about that later, as well as case management and referrals to other services. So these were sort of all of the pillars that they provided. And then the quote on the right is from an in-depth interview that we did with a woman from Sudan who said that the peer specialist told us about the clinic. She gathered the women and talks about that. We are like in a community. That's the first time I know that there's clinics that can take care of women like that. So next slide, please. So this just describes the specialty clinic that we set up for our services at Drexel. The photo is a real photo. It's not a stock photo. So you'll see a client there with one of our lead physicians, as well as a resident in training. And on the left there is our CHW, Sally, who would provide medical accompaniment, actually bringing women into the clinic, going into their appointment, providing interpretation, answering questions, and just being that emotional support, you know, because it is a very intense and emotional topic. And so, you know, we had comprehensive reproductive health care services, a dedicated phone line. Our typical client visits at this clinic generally are 15 minutes. We realize that's really not enough for a new visit with someone who may not speak English. You know, and so we were able to dedicate, you know, longer visits for this program. Had sliding scale fees for the uninsured, and did a lot of history taking tailored for these women. Next slide, please. And so this sort of shows how we integrated the CHWs into our clinical team. They helped to schedule appointments. Like I said, they provided medical accompaniment to our clinic, assisted with interpretation, served as cultural brokers, provided a lot of education to clinicians. One of the barriers we encountered was that the traditional medical school curriculum does not include education around FGMC, even for OBGYNs. And so there was a lot of education that needed to happen around that, as well as assistance with the case management and referrals. Next slide, please. So this just shows, again, how, you know, having the CHWs integrated with our clinical team really provided an additional value and benefit to clients because those CHWs had the cultural context, the moral support, the language, and so the benefits resulted for the clients fuller knowledge of self, access to preventive care that they may not have accessed before, feeling more valued, feeling more comfortable seeking care, relationship building, and eased communication. Next slide, please. So one of the key services that our CHWs provided was also facilitating support and sex therapy groups for affected women. And so our support groups addressed a wide range of needs and experiences for affected women. They were led by the CHWs. They focused on understanding healthcare access and health insurance, stress management, family communication, and preventive care education. And then we also created sex therapy groups that actually emerged out of needs that were expressed by the clients that we saw. So when we originally planned out this program, we didn't have sex therapy groups, but you know, our CHWs communicated that there was such a need for this, a desire for this expressed by the clients, that we ended up establishing this. So we found a licensed clinical sex therapist who would meet with women to discuss a lot of the sexual health issues that they were having. And so for both of these groups, we made sure that they were free to attend for everyone. They were in accessible community-based settings, and they were participant-driven. And the CHWs were there to provide language interpretation and guidance. So oftentimes, we were operating in multiple languages. We had, you know, a lot of women from West Africa who would speak languages like Bambara, French, other languages, and we also had a lot of women from Eastern Africa who were Arabic speaking. So we were juggling with a lot of languages, but that was so essential to have the CHWs. So next slide, please. And these are just some of the outcomes from our program. We were able to deliver clinical services to over 300 women who came from 17 different countries, and delivered over 460 clinical visits, and over 50 patients were seen for an asylum exam. We hosted 18 sex therapy groups and 13 support groups, and we also completed 58 in-depth interviews about women's attitudes towards FGMC. And our CHWs who provided all the peer support were also served as researchers and conducted some of these qualitative interviews. So they actually received the city human subjects researcher training, and were, you know, full members of our research team. They had a role in devising the design of the interview study, the questions that we would be asking, and all of that. So next slide, please. So these are some lessons learned. Peer-to-peer outreach is essential for building trust between providers and clients and promoting cultural competency in the clinic. It enhances access to health services that are tailored to needs. And we learned that clients are very interested in discussing their experiences with FGMC once that trust is established and once they feel safe to do that. So we did identify a number of additional needs. Preventive care was a new concept to many clients. Open discussion of reproductive health and FGMC would often occur for the very first time in our clinic because it is such a taboo topic. Sexual health is an overlooked and under-resourced issue, and much more research is needed to understand the health effects faced by women with FGMC in the US, the attitudes and beliefs, around healthcare, as well as best practices to prevent the continuation of this practice in future generations. So next slide, I think that is the end. Yeah, so just thank you to everyone here. I want to acknowledge the tremendous CHWs we worked with. I will say I talk about this program in the past tense only because unfortunately in 2019 our Drexel Medical Clinic was shut down when our major public hospital closed. And so this program no longer exists, sadly, because of the hospital closure. However, African Family Health Organization is still operating. They still have CHWs on the ground. They're amazing. I put their link in the chat. And the Nationality Service Center also is still operating. So, and there's my cat. So yeah, I will wrap up there. Thank you. Yeah.
Thank you so much to all of our wonderful panelists. Thank you for all of those wonderful presentations that you guys have shared with us. Emily, hello to your cat.
Yes.
So now we are going to segue into a panel discussion for the next 10 to 15 minutes. So if there are any questions that you guys have for our panelists, please feel free to put them in the chat. Feel free to come off of mute and raise your hands as well. And like I said, but I will start off with an opening question. So why is it important to be intentional about the placement of community health workers? I know you briefly touched upon that in your presentations, but just to kind of recap, why is it really intentional about the placement of community health workers? And I'll first pass it to Joyce, if that's okay.
Oh, thank you very much. And you all, I want to explain that I was invited and delighted to come on board, but this was less than probably 30 minutes before we started. And therefore, I don't have those wonderful slides that the other panelists have. So please forgive me. They have done a beautiful job of providing slides. Why then, to answer your question, why is it important to be intentional? Because they are so essential to reaching the people that need the services. We absolutely are not able to do it as health professionals sitting in an office, sitting in a clinic. The community members get out there, they open doors, they know the language of the communities that they go into. Hopefully, and most of the time, those that I know about, and I saw someone in the chat mention Bull City Strong, the persons from the community are selected because community workers are selected because they know the community. And I wouldn't open my door unless I could relate to you in some way, fashion, or form. And often the people that are providing the services do not have that ability to transition and understand the community. There's a big gap, the language gap. I remember going to a doctor once who I told him I worked in Eastern North Carolina, and he said to me that the people there do not care about their children. He was doing a test on me when you're conducting electrical probe, and I didn't want him to hurt me, so I didn't completely say how I felt. I said, "What do you mean?" And he said, "Well, the family members come and they don't bring their kids to the doctors for days. The kids will be sick for days before they ever bring them in." He said, "They just don't care about their children." He was so uninformed. So it's important that we have people there who understand. Do I think this doctor meant to be mean or cruel or uninformed? No, but he was. That's my answer.
Thank you so much. I'm going to pass it to Shaquita to follow up. Add anything?
Sure, Ms. Joyce, that was beautiful what you said. I would just like to say it's intentional because we don't want to continue to waste. We don't want to waste time. We don't want to waste resources. We want to be able to first and foremost stop doing what we've always done It resulted in the outcomes that we have now. We focused on doing something different, speaking with different people and bringing different people to the table. Because not every person that I would say should be placed. First of all, let's look at the requirements of the CHW. Let's say that's hired maybe from the hospital. How are those applications structured? Are they requiring a certain type of degree? Or have you seen an application where it gives you an option to put how much lived experience do you have as a teen mom or someone that has suffered substance abuse or someone that, like I said, had their children early or had cancer or diabetes? This is the relational component to that. Who can actually validate the statistics that they conduct when they do community health data assessments every 4 years in all counties? Who is being assessed to bring that information back? So it's a bunch of different things that we have to really look at whenever when we're placing CHWs. Are we putting people in different places where they are going to be able to reach the population that we intend for them to reach? Or are we going to continue sending people that cannot relate culturally to the table to people who are cultural? If that makes any sense. You can't put everybody at every table, but there's a problem in that a lot of the tables are not being filled with the people that know what they're talking about. There's a lot of money and resources.
Thank you so much. And then just going back, Joyce, there was a follow-up question for you in the chat. Jacqueline would love to hear more, or love for you to expand more around the fashion or form. What a lovely phrase, but they want to hear more.
I thank you for saying that. And Jacqueline, with Jackie Holiday, could you tell me more about that? I'm not sure. I don't understand the question, and I don't remember what I said. So please help me out.
Joyce, it's Jackie. Hopefully you remember me from all kinds of stuff. So you look amazing. Thank you for being here.
Thank you. Thank you for being here.
I would have had a heart attack if I had to try to prepare that quickly. So, I mean, you are just amazing. So there's different ways, right, that we kind of get at this. I'll open my door for you.
Oh.
And or my door will open or I will not open. And I thought I heard you say that you would or would not open a door based upon the fashion or form. And I'm like, fashion, that's the coolest thing I've heard all day. So maybe I heard it wrong, but it was just so gentle.
That sounds so good. I don't remember saying that, but I love it. I'm going to take it and I'll pretend that it was mine. Now you've given that to me, Jackie. So
Alexis, we recorded this, right? We're going to go back now, Joyce.
Yes, we have it recorded, so we'll let you know your exact words.
All right. Anyway,
okay.
Appreciate you.
But I meant that people will not open their door unless they are able to relate to a person. That I wouldn't open it based on how.
I lost Joyce, y'all. Did you for just a bit?
Yeah.
Yes, we lost her, I think.
All right. Well, she'll be back. I had a neighbor who she was Italian. She's from upstate New York, and I ran into her because I'm from upstate New York, and I'm now in Chapel Hill. And she said something like, "Your door opens and closes like mine." And like that was what I thought she was kind of capturing is this. There was just so much culture. You didn't have to describe it all, whether it's the food or the kids are running around. And anyway, so Joyce sounded very poetic there, and I just wanted to raise it up. So we'll get it on recording. We'll get it on recording.
Yes, I will make sure to quote it and we'll put it out there. And again, yes, we'll put it out there. Thank you, Joyce, and thank you, Jacqueline. So we had another question that was popped in the chat from Lori. She's interested in hearing about the use of community health workers for an aging population. Is there trainings for community health workers working with this age group? So Emily or Shaquita, I'll open up the floor to you.
Off the top of my head, I don't know, but I was actually going to direct you to the National Association of Community Health Workers, NACHW. They're just a fantastic resource for all things CHW related.
Shaquita.
Yeah, absolutely. So just recently, I mean, just now, Shackle Free have partnered with USAG to do a COVID-19 and flu vaccine. You guys saw that slide. I was reading over the class. But we were able to vaccinate almost 6,000 individuals that are 60 and over or living with disabilities to support their vaccination efforts for COVID, for flu, RSV. Our senior care program, our senior care directors are on here on this call. That is the most relational group, the most working and hardworking group, some of the most knowledgeable community health workers. Lori, they have the answers to all the questions and they fry some great fish. They know how to bring people out. That's the thing that I think we missed out on. We usually get caught up sometimes on credentials. To be honest, everybody needs credentials, but the first thing we start with are lived experiences. The seniors have been around for a long time. They know this person, that person, and 9 times out of 10, even the younger ones, even the gang members, they respect certain seniors in the community and they won't even bother them. So they have a rapport. Their grandmothers, their grandfathers, they have a rapport in the community. So in answer to your question about CHW training, Shackle Free has a dynamic Google Classroom that we're building. We would love to incorporate that classroom in every community college and university across the country. It's because it specifically targets how we get our seniors digitally trained so they're able to attend a Zoom. Everything just gets all the way down to the nitty-gritty of exactly how we treat them and then how we empower them to treat each other. They know their needs better than we do. So empowering them, yes, absolutely. There are materials out here, Lori, and if you'll drop your email address in the chat, our marketing director or Robin or Julian or Leatrice on our team and Glendora, they'll make sure that you get the information that you need. And that goes for anyone that's interested in our classroom that we're building. Thank you.
Thank you so much. And again, yes, please put your information in the chat so they can follow up with you with that wonderful information. And we received another question in our chat. Have there been any HIPAA issues? So I'll open up the floor to either one of you to be able to answer that question there from Gregory in the chat put in.
I'll jump back in, I guess. No HIPAA issues, Mr. Shanton, Dr. Shanton, one of our great partners. No HIPAA issues because we generally require that individuals do an assessment in the beginning of coming into our program, no matter what it is, even for our volunteers, even for our CHWs, about the amount of information we're able to release to anyone that contacts us, or if we're trying to help them to do something that may be income-based. And our community health worker navigators, we have a great person that does our intake, Wanda Sharpley. She's a nurse, and she's able to do that one-time assessment, everybody, to that story one time, not have to thank people for telling this story over and over again. That's some of the most painful process in intake, is someone having to tell their story more than one time. Take that permission, and that opens the door for us to be able to serve our participants. When you come in, we're doing that Maslow's assessment of you, every one of those levels. We're going to ask you for that permission. With our aging program, we also do not ask for specific names or the demographic information that will actually identify a person. They're given that option to release that information. So therefore, we've been very careful with our HIPAA protocol.
Mm-hmm. Yeah, I'll just add, we did not have any HIPAA issues either. Training is a big part of that, and just education for everyone involved on what is HIPAA, what are the regulations. But I think in our program, because we were dealing with such a sensitive topic, there was a shared understanding that it was so important to maintain the confidentiality, just because of the nature of the topic. And if I could just add a comment on the first question, the intentionality question, just one thing I wanted to add was that I think a really important reason to be intentional about placing your CHWs is to avoid unintentional harm. Often our CHWs work with communities who are marginalized or underserved or vulnerable in some way, whether it's something like FGMC, whether it's people who use drugs, people involved in sex work, in the criminal justice system. And not having an intentionality or understanding around those populations and communities can actually, lead to, stereotyping or insensitivity that can really turn people away from seeking care. And so we really want to avoid that. So yeah, just, avoiding those unintentional harms, just by being able to approach people where they are, in a human way is so important.
Yes, those are all wonderful responses. And again, thank you both for being able to take the time and answer those. We do have time for at least one more question. And with that, I would just love to be able to hear, for you guys to be able to share, with all the great knowledge and information that you shared with us today about the programs that you have done and the initiatives that you have done within your organizations, how can we continue to support CHWs, and what training, and how can we improve on, just emphasizing the need for community health workers? What can we do in a sense to help boost that need, and just for people to know that, hey, community health workers are essential. So what are some, I guess, suggestions that you guys would have, or what support and training do you think will be necessary for that?
Sure, I can go. Yeah, there are a lot of things that come to mind. One is, if you're in an academic system or a medical system, advocating for the importance of CHWs and the role of CHWs, in advancing that work, encouraging clinicians to try to link with community-based organizations who are working with folks who may have CHWs. And then another thing is also talking to legislators and policymakers who can really create legislation to support the creation of jobs and integration of CHWs. Yeah, and I'll pass it on.
And I'm just going to recite the question, Joyce. We were just briefly talking, we're just wrapping up our panel discussion, just kind of seeing the overall support that is needed for community health workers, to support and the training that's needed, I guess, for community health workers. So I'll either pass it to you or Shaquita to answer that.
Can you hear me?
Yes.
Okay. Well, thank you. My computer died, and I don't, for some reason, so I'm on my phone. I think it's essential to have the organization and leadership, and I agree with what the comments I heard earlier, but having an organization whose leaders understand the importance. I work for Durham County Health Department, and funding now that comes from a grant or from our county commissioners. And if they understand and support it, and they have been very supportive, Durham is one of the best places you can live as far as healthcare and having compassionate members. That's great. And getting out and putting that vote out so you know who you're getting in leadership. But also there are opportunities, I know, for grants. At least there used to be. I haven't seen, I know there are grant opportunities out there that help. That's pretty much what I can think of. Making your voice heard, continuously is so important. Thank you.
Thank you. And Shaquita, if you don't mind giving you a different question or giving you a different question and kind of adding on to that one. We had one pop in the chat, so I just want to touch bases on before we close out today. How can we come to hopefully hire community health workers to engage in research projects with us? For instance, testing out new processes to include community health workers in team-based clinical care. How can we hire them for some of their time such that they can still have time to do what they already do as community health workers already? So I'll let that be the last question that I'll let you close out on this for Shaquita. So floor is yours.
What a great way to close out everything is to talk about how we can get involved. We need to pay them a living wage. I'm not talking about minimum wage. I'm talking about a living wage. Be billable components in Medicaid and Medicare. There should be no there should be no insurance agency right out there right now, whether it's Healthy Blue or any of the new Medicaid expansion involved entities that are not required to have community health workers and navigators that help these individuals to rise from crisis to thriving. Instead of using our beauty and barbershops as we've been doing for so many years and not putting one dime into the light bill or anything inside of those trusted spaces. That's our goal, involving them in the equity team and let them have a sit at the table when we're developing grants, and also getting the community to come together if it's conducting fundraising. You know, all the things that we should really be doing in the community-based organization world, and plus having entities when they're looking for CHWs, don't advertise at NC Works all the time and only just look at that one spot. Come to your community-based organization and see who is actually in there working, who's cleaning the fish, who's catching the fish, breading the fish, frying the fish, teaching people how to fish. That's where you need to go. Stop going to, college people, yeah, I have a degree in all of those things, and I'm not downplaying that at all. But where we need to do is empower the ones that don't. And when we start doing that, then we'll see better results for the whole entire country. A lot of the issues that we have now are just operating under a spirit of people who are not actively living the lives they're trying to change. And so we change that narrative, then we become more effective. And we can pay people, included in our RFPs.
Thank you so much. I always like to joke with Shaquita and say, thank you, Pastor Shaquita, for the closing remarks. We joke on the phone all the time. I say she closing us with the closing remarks. And so with that, thank you again to all of our wonderful panelists. I was just saying this morning, I think this is a great way to close out Women's History Month by having three women panelists. So this is just wonderful. And again, I'm just thankful for everyone that's here today. So I'm going to pass it back to Sharice for our evaluation, post-training evaluation real quick.
Yeah, thank you so much, Alexa, Shaquita, Joyce, Emily, for participating in this really insightful conversation. I wish we can go a little bit longer, but I do want to be respectful of people's time. But yeah, CCPH is always trying to improve the way we share knowledge, and we would really appreciate your insight and ideas on how we can do that. So we invite you to take, the next 2 minutes to complete this very short evaluation. I believe Danae put the link in the chat, and the QR code is also on the slide. But, please just take this short evaluation so we can improve our training sessions and our shared learning spaces. And actually, we have a bit of time. Actually, no, we're running out of time, so I'm just going to close up. But if you don't have time to take the evaluation now, I will send it all to all attendees right after this workshop. And our last slide, thank you so much for your time. Again, thank you to the Spanish interpreter, Sandra and Annabelle as well. And again, to the panel, Shaquita, Joyce, Emily, and of course, Alexis. Please visit our website at ccphealth.org. And we hope you have a lovely day. Thank you.